Dr. Richard Thornton barely glanced up when the locum surgeon walked into the surgical briefing room. His eyes remained fixed on the imaging scans displayed across 3 monitors, showing the intricate vasculature of a patient scheduled for afternoon surgery. "You're the locum replacement?" he said, his voice carrying that particular tone of disappointment reserved for unwelcome surprises. "We specifically requested someone from Johns Hopkins, Doctor." Elena Vasquez adjusted the tablet under her arm with movements that were economical and practiced. Her dark eyes took in the room quickly, scanning the arrangement of chairs, the position of the monitors, the exits. "Old habits. My credentials were cleared by your board, Dr. Thornton," she replied quietly, her voice steady but not confrontational. Thornton finally looked up, taking in the woman standing before him. Mid-30s, he guessed, wearing simple navy scrubs that looked like they'd been through 100 wash cycles. No jewelry except for a tactical watch on her left wrist, the kind military personnel wore. Her black hair was pulled back in a low, tight bun that revealed small scars along her hairline. Burns, maybe. Or shrapnel marks. "Cleared doesn't mean preferred," Thornton said, returning his attention to the scans. "This is St. Michael's Medical Center. We have standards that go beyond mere credentials." He gestured toward the conference table where 6 other surgeons sat. All men, all watching the exchange with varying degrees of interest. "You'll be covering routine cases for the next 3 months while we complete our administrative restructuring. Dr. Park will orient you to our protocols." Dr. James Park, a cardiovascular surgeon in his early 40s, nodded from his position near the window. His expression was neutral, professional. But Elena noticed how his eyes lingered on the scars visible on her hands as she set down her tablet. "Welcome to St. Michael's, Dr. Vasquez. We run a tight ship here. Protocol-driven, evidence-based medicine. Dr. Thornton has maintained a 94% success rate in cardiothoracic surgery for 15 years. That's impressive," Elena said simply. Her fingers moved across the tablet screen, pulling up the day's surgical schedule. "I see I'm assigned to OR3 starting at 1600 hours. A valve replacement," Thornton said dismissively. "Routine. Even a locum should handle that without complications." He turned to address the other surgeons. "Gentlemen, let's continue with the morning briefing. We have 6 procedures scheduled, and I want to discuss the Marquez case." Elena moved toward an empty chair at the far end of the table, but something made her pause. Her eyes had caught on one of the imaging scans still displayed on Thornton's monitor. The patient from OR3. She'd seen that particular pattern of calcification before, in places where diagnostic equipment wasn't state-of-the-art, where you learned to read images with more than just textbook knowledge. "Dr. Thornton," she began carefully, "the valve replacement patient. Has anyone reviewed the posterior wall of the ascending aorta?" The room went quiet. Thornton's jaw tightened visibly. "Dr. Vasquez, the imaging has been reviewed by 3 attending physicians, including myself. The case is straightforward aortic valve stenosis with planned replacement. Your job is to execute the procedure, not to second-guess our diagnostic protocols." Elena nodded slowly, making a mental note. She'd learned long ago when to push and when to observe. In her experience, the second option kept you alive longer. Understood. As the briefing continued, Elena found herself studying the other surgeons. They deferred to Thornton reflexively, agreeing with his assessments, nodding at his pronouncements. It was a hierarchy she recognized, though not one she'd operated under in years. In field hospitals, rank mattered less than results. Here, in this pristine conference room with its leather chairs and perfectly controlled temperature, different rules applied. After the briefing ended, Sharon, a veteran nurse who'd been sitting quietly in the corner, approached Elena in the hallway. "That took courage," she said quietly, referencing Elena's question about the imaging. "Thornton doesn't like to be questioned, especially not by temporary staff." Elena was checking her tablet, pulling up the patient's full medical history. "I wasn't questioning. I was clarifying." Sharon studied Elena's hands as she worked, noting the fine white scars across both palms. "Those look like field medicine burns," she observed. "My son's a Marine. The medics he works with have similar marks." Elena's fingers paused for just a fraction of a second before continuing. "Some medical equipment runs hot in challenging conditions," she said neutrally. She secured her tablet and met Sharon's eyes. "Where's the surgeon's lounge?" "I need to review this case before OR time." "Down the hall. Second door on the left." Sharon's expression was thoughtful. "Dr. Vasquez, I've worked here 17 years. I've seen a lot of surgeons come through these doors. You move differently than most of them." "How so?" "Like someone who's used to working in places where standing still gets you killed." Sharon's voice was quiet but certain. "My son learned that in Kandahar." "Where did you learn it?" Elena adjusted the watch on her wrist, an unconscious gesture that spoke of checking tactical time in high-stress situations. "Experience teaches us all different lessons," she said finally. "Thank you for the directions." As Elena walked away, Sharon watched her go. The way the younger surgeon moved through the corridor wasn't random. She was scanning exits, noting camera positions, maintaining awareness of everyone around her. That wasn't civilian medical training. That was something else entirely. In the surgeon's lounge, Elena found a quiet corner and pulled up the imaging scans from her afternoon patient. She zoomed in on the posterior aortic wall, adjusting contrast and brightness. There, that subtle irregularity that the other physicians had missed. It could be artifact from the CT scanner, or it could be the beginning of a dissection that would turn a routine valve replacement into a life-threatening emergency. She made detailed notes, cross-referencing with similar cases she'd seen. Not in textbooks, not in prestigious teaching hospitals, but in places where CT scanners ran on unreliable generators, and you learned to read images by what they didn't show as much as what they did. Her phone buzzed. A message from an unknown number. "Heard you took a position at St. Michael's. Watch your back." Thornton's reputation isn't just about success rates. Some of us tried to innovate there. Didn't end well. Former colleague, MSF. Elena deleted the message and returned her attention to the scans. 3 months, she reminded herself. 3 months covering routine cases, staying invisible, avoiding complications. Then she'd move on to the next temporary position, the next city, the next hospital where nobody asked too many questions about the gaps in her CV or the scars she couldn't quite hide. But as she stared at that imaging scan, at the subtle irregularity that could mean nothing or could mean everything, Elena knew that staying invisible might not be possible. Not if that patient's life depended on seeing what others had missed. Not if her instincts, honed in places where second chances didn't exist, were telling her that something was wrong. She closed her eyes briefly, and for just a moment, she was back in a tent hospital with mortar fire in the distance, working by the light of a battery-powered lamp, making impossible decisions with limited information. Then she opened her eyes and was back in the pristine surgeon's lounge of St. Michael's Medical Center, where the coffee was excellent and the expectations were clear. Stay in your lane. Follow protocol. Don't make waves. Elena looked at the imaging scan one more time, then began preparing her notes for the afternoon surgery. Because sometimes staying in your lane meant watching people die. And that was one lesson she'd never learned to accept. If you want to see how this rogue doctor defies every protocol to save a life everyone else gave up on, make sure you subscribe to Emergency Heroes Stories. Because what Dr. Vasquez does in the next hour will redefine what's medically possible. Where are you watching from? Drop a comment and let us know. Because what happens in OR3 is about to change everything at St. Michael's Medical Center. Part 2. The residents' lounge hummed with the familiar sounds of late afternoon. Coffee brewing, keyboards clicking, the muted conversations of exhausted surgical staff grabbing moments of rest between procedures. Dr. Elena Vasquez had become a topic of discussion faster than she'd anticipated. She's been here 3 hours and already questioned Thornton in front of the entire surgical team, one resident was saying, his voice carrying just enough to be overheard but quiet enough to maintain plausible deniability. Either she's incredibly brave or incredibly stupid. Doctor. Amanda Chen, a third-year resident, glanced toward the corner where Elena sat reviewing patient files. Did you see those scars on her hands? Those aren't from medical school accidents. They look like field burns. My uncle was an Army medic. He had similar marks from working with cauterization equipment in forward bases. Maybe she did rural medicine somewhere, another resident offered. Volunteer work in developing countries or something. Doctor. James Park entered the lounge, making the residents' conversation halt abruptly. He poured himself coffee and approached Elena's table. Dr. Vasquez. Do you have a moment to discuss the afternoon case? Elena looked up from her tablet, her expression neutral. Of course, Dr. Park. Park sat across from her, keeping his voice low. That question you raised in the briefing about the posterior aortic wall. What made you notice that particular area? The imaging showed subtle irregularity in the wall thickness, Elena replied, pulling up the scan on her tablet. Here, at the junction with the ascending aorta. It could be artifact from the scanner, or it could indicate early dissection. Given the patient's history of hypertension and the calcification pattern, I thought it warranted mention. Park studied the image, then looked at Elena with new interest. That's remarkably detailed observation for a routine review. Most surgeons wouldn't catch something that subtle on initial screening. Most surgeons haven't worked in places where missing subtle details means losing patients you could have saved. Elena's voice was matter-of-fact, not boastful. Where I trained, you learned to see what the equipment didn't show you. And where was that? Park's question was casual, but his attention was focused. Various locations. Elena closed the tablet. Resource-limited settings where you made do with what you had, and learned to trust your instincts as much as your technology. Before Park could press further, Dr. Thornton entered the lounge. His presence commanded immediate attention. Dr. Park, Dr. Vasquez, I wanted to clarify the afternoon procedure. The valve replacement is straightforward. Dr. Vasquez, you'll be lead surgeon with Dr. Park supervising. Standard aortic valve replacement protocol. The patient is 52 years old. Stable cardiovascular history beyond the stenosis. Simple in, simple out. Elena met Thornton's gaze steadily. And if complications arise, then you escalate to Dr. Park immediately. Thornton's tone made it clear this wasn't a suggestion. This is St. Michael's, Dr. Vasquez. We don't improvise. We follow established protocols that have been proven effective over 15 years of exemplary surgical outcomes. Understood, Elena said quietly. After Thornton left, the residents resumed their conversation, though more quietly now. She barely reacts to anything, Amanda Chen observed. Thornton just put her in her place, and she didn't even flinch. That's not submission, another resident countered. That's someone who's learned when battles are worth fighting. I've seen that before in military personnel. They pick their moments. You think she's former military? Those scars, that posture, the way she scans every room she enters? Amanda shook her head. She's definitely seen some things beyond medical school. In the scrub room at 1547, Elena prepared for surgery with methodical precision. Dr. Park joined her, observing her technique. You scrub like someone who's done this in field conditions, he remarked. Very thorough, but efficient, wasting no time or resources. Old habits, Elena replied simply. In some places, water for scrubbing is precious. You learn not to waste it. Park began his own scrub. Dr. Vasquez, I want you to know that despite Thornton's rigidity, I keep an open mind. If you see something during the procedure that concerns you, I want you to speak up. Patient safety trumps protocol. Elena nodded. Thank you, Dr. Park. That means more than you might realize. They entered OR3, where the surgical team was completing final preparations. The patient, Robert Morrison, lay anesthetized on the table. The anesthesiologist, Dr. Lisa Patel, looked up from her monitors. Vitals are stable. BP 130/80, heart rate 72, oxygen saturation 98%. Ready when you are. Elena positioned herself at the table, her hands steady. Scalpel. The instrument was placed in her palm with practiced efficiency. She made the median sternotomy incision with movements that were confident but not rushed. Each cut was deliberate, precise, measured. The surgical nurses exchanged glances. They'd worked with dozens of surgeons, and something about Elena's technique was different. Not wrong, just different, more economical, as if every motion had been refined to eliminate anything unnecessary. Sternal saw, Elena said. The saw was handed to her, and she divided the sternum with perfect alignment. Minimal blood loss. Textbook perfect so far. Dr. Park watched from his position, noting the efficiency. Good exposure. Continue. Elena placed the retractor, opening the surgical field. pericardium coming into view. I'm going to inspect the aortic root before we proceed with valve access. That's not standard protocol, Park said, though his tone was curious rather than critical. We typically go straight to the valve. Indulge me for 30 seconds, Elena replied. Her gloved hands carefully palpated the aortic tissue, moving methodically along the posterior wall. There. What is it? Park leaned closer. Thickening in the posterior wall. Early dissection, just as I suspected from the imaging. If we'd proceeded with standard valve replacement without addressing this, we'd have intraoperative rupture within the hour. Dr. Patel checked her monitors. Vitals are still stable. No signs of acute dissection. Not yet, Elena said, her voice calm but firm. But the tissue integrity is compromised. Dr. Park, we need to convert this to a valve replacement with ascending aortic repair. This patient needs more than what we planned for. Park hesitated. That's a significant escalation. Dr. Thornton needs to be consulted. We have maybe 45 minutes before this becomes an emergency dissection, Elena said, still working. With respect, Dr. Park, by the time Dr. Thornton scrubs in, reviews the situation, and makes a decision, we'll be in crisis management instead of preventive repair. How can you possibly know the timeline? Park demanded. Because I've seen this exact presentation 17 times, Elena replied, her hands never stopping their careful assessment. 12 times in hospitals with full diagnostic capability, 5 times in field hospitals where we caught it during surgery. Every single one that we delayed addressing ended in emergency repair with significantly higher mortality risk. The OR fell silent except for the beeping of monitors. Park looked at the exposed tissue, at Elena's certain hands, at the patient whose life hung in the balance. This is your call, Dr. Vasquez. But if you're wrong, both our careers are finished. Elena met his eyes. I'm not wrong. And this patient doesn't care about our careers. He cares about surviving. Park took a breath. Proceed with the repair. I'll take responsibility for the decision. And someone page Dr. Thornton. He needs to know what we're doing. As Elena began the complex repair, working with speed that seemed impossible for someone who'd supposedly never operated at St. Michael's before, word spread through the hospital. The locum surgeon in OR3 had identified a life-threatening complication and was performing a procedure well beyond the original surgical plan. Residents gathered in the observation gallery, nurses whispered in hallways, and Dr. Richard Thornton, receiving the page while reviewing files in his office, felt his blood pressure rising. In OR3, Elena worked with focused intensity. Aortic clamps. Bypass initiated. I need to replace this section before the dissection extends. Park, can you expose the arch? Park moved into position, working alongside her. Your technique is exceptional. This isn't community hospital medicine. This is specialized training. Where did you really learn this? Elena's hands continued their precise work. Places where you either learned fast or watched people die. Places where equipment was limited, but the need for perfection wasn't. Places that taught me to trust what my hands tell me more than what my eyes see. As she worked, the surgical team watched in growing amazement. The locum surgeon who'd walked in that morning as an unknown temporary replacement was performing cardiovascular surgery that most of them had only read about in journals. And outside OR3, Dr. Thornton was putting on his scrubs, preparing to observe exactly what Dr. Elena Vasquez was capable of. What he witnessed would challenge everything he thought he knew about medicine, protocol, and the value of experience earned far from prestigious medical centers. Part 3, Dr. Thornton entered the observation gallery above OR3, his face a mask of controlled fury. Through the glass, he could see Elena working with focused intensity, her hands moving through the surgical field with precision that made him pause despite his anger. Beside him, 3 residents stood watching, their expressions ranging from amazement to disbelief. Dr. Amanda Chen was the first to notice Thornton's arrival. Dr. Thornton, she said quietly, her voice uncertain. Dr. Vasquez identified an aortic dissection that wasn't visible on the preoperative scans. I'm aware, Thornton said tersely. His eyes never left Elena's hands. She escalated a routine valve replacement without my authorization. In OR3, Elena's voice carried through the intercom with calm authority. Aortic clamp in place. Cardioplegia administered. Myocardial protection achieved. Dr. Park, I need you to retract the arch gently. I'm going to resect this dissected section and prepare for graft anastomosis. Dr. Park positioned the retractor with careful precision. His initial skepticism had transformed into something approaching awe as he watched Elena work. The tissue quality is worse than the imaging suggested, he observed. How did you know this was here? Pattern recognition, Elena replied, her hands never pausing. The calcification distribution, the wall thickness variations, the patient's hypertensive history. In aggregate, they pointed to early dissection. I've seen this presentation before. Where? Park asked, genuinely curious now rather than challenging. Places where waiting for perfect diagnostic confirmation meant watching patients die on the table. Elena positioned the vascular graft. Suture. 4O proline. The surgical nurse handed her the suture with steady hands, but her eyes were wide. She'd assisted hundreds of cardiac surgeries, but Elena's technique was unlike anything she'd witnessed. Each suture was placed with mathematical precision, the spacing exact, the tension perfect. There was no hesitation, no second-guessing, just fluid execution that spoke of extensive experience. In the observation gallery, Dr. Chen leaned toward Thornton. Her technique is remarkable. Those are field surgery sutures, aren't they? The interrupted pattern designed for maximum strength with minimal material. Thornton's jaw tightened. Where did you learn to recognize that? My uncle served as a Navy corpsman. He showed me photos of surgical techniques used in forward operating bases. Dr. Vasquez's suturing pattern matches exactly. Down in OR3, Elena completed the first anastomosis. Proximal graft attachment complete. Checking for leaks. Dr. Patel, how are our patient's vitals? The anesthesiologist consulted her monitors. Remarkably stable. Temperature 32 degrees Celsius, heart arrested, bypass flows optimal. He's tolerating the procedure well. Good. Elena moved to the distal anastomosis. This is the critical connection. If this fails, we lose him. Her voice remained steady, clinical, betraying no emotion despite the life-or-death stakes. Dr. Park watched her hands create the vascular connection with flawless technique. I've been doing cardiac surgery for 12 years, he said quietly. I've never seen anyone work this fast with this level of precision. Not even Dr. Thornton. Speed comes from necessity, Elena replied. When you operate in environments where you don't have luxury of time, you learn efficiency. Every second counts when resources are limited. What kind of environments are we talking about? Park pressed. Resource-limited settings. Conflict zones. Places where Médecins Sans Frontières sends surgeons when traditional medical infrastructure has collapsed. Elena completed another suture. There. Distal anastomosis complete. Ready to release clamps and check perfusion. In the gallery, Thornton's expression had shifted from anger to something more complex. He was watching a surgical performance that rivaled his own best work. Executed by a surgeon he'd dismissed as a temporary replacement just hours earlier. You said she questioned the posterior aortic wall in this morning's briefing, he said to the residents. Yes, sir, Amanda confirmed. You told her the imaging had been reviewed by 3 attendings. I did. Thornton's voice was quieter now, and she was right. We all missed it. Down in OR3, Elena was removing the aortic clamp. Clamp off, resuming cardiac activity. She watched the heart carefully as it began to contract again. Good perfusion through the graft. No leaks visible. Dr. Park, can you see any areas of concern? Park examined the surgical field thoroughly. Everything looks perfect. The graft is seated well, the anastomoses are leak-free, and the valve is functioning properly. Elena allowed herself a small moment of satisfaction. Patients coming off bypass. Dr. Patel, what do you see? Vitals strengthening, Patel reported, wonder evident in her voice. Blood pressure rising to normal parameters. Heart rhythm regular. This is remarkable recovery. Let's close the pericardium and start sternal closure, Elena said, already moving to the next phase. She worked with the same methodical efficiency she'd shown throughout, each layer closed with perfect technique. The surgical nurse assisting her whispered to her colleague, "I've been in cardiothoracic surgery for 8 years. I've never seen a complex repair completed this smoothly." Her colleague nodded. "And look at the time. We've been in here 3 hours and 12 minutes. A repair like this normally takes 5 to 6 hours. In the observation gallery, Thornton checked his watch and felt something he rarely experienced. Genuine surprise. 3 hours, 12 minutes from first incision to closure preparation, he said aloud, for a valve replacement that became an emergency aortic repair. That shouldn't be possible. "But it's happening," Amanda Chen said softly. "Dr. Thornton, who is she really?" Before Thornton could respond, his phone buzzed. A message from the hospital's administrative director. "Richard, need to discuss Dr. Vasquez's credentials. Her CV shows gaps. MSF confirmed 7 years in field operations. Syria, Yemen, Congo. Over 300 cardiac surgeries in conflict zones. Why didn't you review her full background?" Thornton stared at the message, then back through the glass at Elena, who was now supervising the final closure. 300 cardiac surgeries in war zones. That explained the efficiency, the confidence, the ability to work under pressure that would paralyze most civilian surgeons. In OR3, Elena removed her surgical gloves as Dr. Park supervised the final steps. "Patient is stable and ready for transfer to cardiac ICU," she announced. "Projected recovery is excellent barring unforeseen complications." "Dr. Vasquez," Park said, respect clear in his voice. "That was extraordinary surgery. You saved this man's life by catching what the rest of us missed." "I did what any competent surgeon should do," Elena replied, already moving toward the scrub room. "Observe, assess, and act appropriately. That's not standard competence. That's exceptional skill honed by extensive experience." Park followed her. "Experience you haven't been entirely forthcoming about." Elena paused at the scrub room door. "My CV contains all relevant credentials for this position, Dr. Park. What it doesn't contain is protected by various confidentiality agreements with humanitarian organizations. You worked in conflict zones. I worked in places where people needed surgeons and weren't particular about where those surgeons had trained or what their success rates were in prestigious medical centers." Elena's voice carried an edge now. "Places where protocol mattered less than keeping people alive with whatever resources you had available." Before Park could respond, the scrub room door opened and Dr. Thornton entered. "Dr. Vasquez," he said, his voice carefully controlled. "We need to discuss what just happened in that OR." Elena met his gaze steadily. "We successfully completed an aortic valve replacement with ascending aortic repair. The patient is stable and expected to make full recovery. What specific aspect would you like to discuss? The aspect where you escalated a routine procedure to complex cardiovascular surgery without my direct authorization," Thornton said. "The aspect where you demonstrated surgical skills that exceed what your CV suggested. The aspect where you apparently have 7 years of field surgical experience that you failed to mention during your interview. My field experience was documented in my application," Elena replied calmly. "If it wasn't reviewed thoroughly, that's not a failure on my part." The room fell silent. Through the window, they could see the OR team preparing the patient for transfer, the monitors showing strong, steady cardiac rhythms. The evidence of Elena's surgical excellence was undeniable. Thornton took a breath, and when he spoke again, his voice had lost some of its edge. "You were right about the dissection. You saved that patient's life. Your surgical technique is exceptional, but this hospital operates on protocols and hierarchy for good reasons." "Protocols are important," Elena agreed, "but they're guidelines, not absolute laws. When protocol conflicts with patient survival, I choose survival every time. That's what my experience taught me." "Experience earned where?" Thornton pressed. "Syria, Yemen, Congo, South Sudan. Places where hospitals operated in tents and could be destroyed by mortars at any moment." Elena's voice remained steady. "Places that taught me to trust my assessment and act decisively because hesitation meant death." Thornton studied her for a long moment. "Then we need to discuss your role here, Dr. Vasquez. Because you're clearly not just another locum surgeon covering routine cases." "What am I then?" "That," Thornton said slowly, "is what we're going to figure out." Part 4. The overhead speakers crackled to life at 2:47 in the morning. shattering the relative calm of St. Michael's Cardiac Surgical Wing. All cardiothoracic staff to emergency department immediately. Mass casualty protocol. Multiple critical cardiac injuries. All available OR teams stand by. Elena was in the on-call room, reviewing patient charts on her tablet. She'd been at the hospital for 14 hours, but sleep had proven elusive. Old habits from field work. You never really slept when you were responsible for lives. She was moving toward the emergency department before the announcement finished, her tactical watch already noting the time, her mind shifting into triage mode. The ER was controlled chaos. Paramedics wheeled gurneys through automated doors, while nurses shouted vital signs and trauma teams assembled at designated stations. Elena took in the scene with practiced efficiency, her eyes cataloging injuries, assessing resource allocation, prioritizing interventions. Dr. Park appeared at her side, pulling on a trauma gown. "School bus accident," he said tersely. "Returning from regional basketball tournament. 12 injured, 4 with critical cardiac or thoracic trauma. 2 more incoming by helicopter." Elena moved toward the first trauma bay. Her hands were already assessing the patient before anyone gave her permission. 16-year-old male, the paramedic reported. Known cardiac history, cardiomyopathy, was on transplant list, now has severe thoracic trauma from impact. Vitals are deteriorating. The boy's face was pale, his breathing labored. Elena's trained eyes took in the jugular venous distension, the muffled heart sounds, the paradoxical pulse. Cardiac contusion, possibly worse. She looked at the monitor. Ejection fraction was already compromised from his underlying disease, and now this trauma had pushed him into acute decompensation. Dr. Thornton strode into the ER, his presence commanding immediate attention. "Status report," he demanded. 4 critical cardiac cases, Dr. Park said. 2 pneumothoraces requiring immediate chest tube placement, 1 suspected cardiac tamponade, and this patient. He gestured to the 16-year-old. Marcus Webb. Dilated cardiomyopathy. Ejection fraction around 20% baseline. Now with blunt cardiac trauma. Thornton moved to Marcus's bedside, his experienced hands performing rapid assessment. He reviewed the portable echo images that the ER had already obtained, his expression growing increasingly grave. Ejection fraction is down to 15%. Severe contusion to the anterior wall. Mitral regurgitation has worsened significantly. His heart was barely functioning before the accident. Now, he trailed off, but everyone in the trauma bay understood what he wasn't saying. Marcus was dying. "Dr. Thornton, what's the plan?" Park asked. Thornton was silent for a long moment, studying the monitors, the echo images, the boy's deteriorating condition. Finally he spoke, and his voice carried the weight of impossible decisions. "It's over. There's nothing we can do. He needs an immediate transplant, and there are no organs available. Even if there were, he wouldn't survive the surgery in this condition. But there has to be something," Dr. Park protested. "He's 16 years old. Sometimes being a good physician means recognizing when we've reached the limits of what medicine can achieve." Thornton's voice was firm, but not unkind. "We'll make him comfortable. Notify his family. Get palliative care involved." Elena had been standing at the periphery, but now she moved closer. Her eyes never left Marcus's monitor, watching the cardiac rhythm, the blood pressure, the oxygen saturation. All trending downward. She'd seen this pattern before, in places where giving up wasn't an option, because there were no alternatives waiting. A paramedic entered the trauma bay, the same one who'd brought Marcus in. Cole Jenkins, his name tag read. He looked at Elena and his expression changed, recognition dawning. "Wait," he said. "Are you, Dr. Vasquez? Elena Vasquez?" Elena glanced at him briefly. "Do I know you?" "Aleppo, 2019. Cole's voice was certain now. "You operated on my sergeant after the hospital got hit. You improvised a mechanical support system using field equipment when his heart was failing. You kept him alive for 3 days until we could get him to a proper facility." The trauma bay had gone quiet, everyone's attention shifting between Cole and Elena. Thornton's expression was skeptical. "That's quite a story." "It's not a story," Cole insisted. "I watched her work. She saved 8 lives that night with equipment that barely functioned." He looked directly at Elena. "Ma'am, if anyone can help this kid, it's you." Marcus's mother burst through the ER doors at that moment, a nurse trying to keep up with her. "Where's my son? Where's Marcus?" Patricia Webb's face was a mask of terror, the kind Elena had seen too many times on parents in impossible situations. "Mrs. Webb," Thornton began, his voice taking on the careful tone physicians used when delivering devastating news. "Your son's injuries are extensive. His pre-existing heart condition combined with the trauma from the accident. Is he going to die?" Patricia demanded. The words came out raw, desperate. Thornton hesitated for just a moment. "Mrs. Webb, we've assessed Marcus's condition. His heart function is critically impaired. Without an immediate transplant, which we don't have available, I'm afraid it's over. I'm truly sorry." Patricia's knees buckled. A nurse caught her, but her eyes never left her son's face visible through the trauma bay window. "No," she whispered. "Please. He's all I have. There has to be something. Anything." The silence in the ER was profound. Even the ambient noise of the hospital seemed to fade. Elena stood motionless, her eyes moving between Marcus's monitors, the echo images, the available equipment. Her mind was calculating, assessing, running through scenarios she'd executed in situations where failure meant death and success meant buying time against impossible odds. She thought about Aleppo, about the Sergeant Cole mentioned, about the improvised mechanical support systems built from surgical equipment and battlefield ingenuity. She thought about the children in Yemen who'd survived because she refused to accept that some patients were beyond saving. She thought about every lesson learned in places where protocol was a luxury no one could afford. Thornton was already turning away, preparing to give orders for palliative care. The trauma team was beginning to disperse, accepting the chief surgeon's pronouncement. "It's over." Those words hung in the air like a final verdict. Elena took a breath, made a decision, and stepped forward into the center of the trauma bay. Her voice was quiet, but carried absolute certainty. "There's still a way." Every head in the ER turned to look at her. Thornton froze mid-step. Dr. Park's eyes widened. Patricia Webb looked up with desperate hope. "Dr. Vasquez, what are you talking about?" Thornton's voice was sharp. "The boy's heart is failing. He needs a transplant we don't have." "He needs bridge support until a transplant becomes available," Elena corrected. "ECMO won't work with this degree of cardiac dysfunction. Standard ventricular assist devices won't accommodate his anatomy in this acute phase. But there's another option." "What option?" Park asked, moving closer. "Improvised biventricular assist device with non-conventional cannulation," Elena said, her mind already planning the procedure. "I use a transgastric approach combined with direct epicardial support. It's not textbook medicine. It's adapted field surgery. But I've done it 9 times. 7 patients survived. That's not a recognized procedure," Thornton said, his voice rising. "You're talking about experimental surgery with no approved protocol. I'm talking about the only option that gives Marcus a chance to survive long enough to get a transplant." Elena met Thornton's eyes directly. "In 2 weeks, maybe less, a compatible heart will become available. But only if Marcus is alive to receive it." "This is insane," Thornton said. "You want me to authorize an unapproved experimental procedure on a minor and critical condition? I want you to choose between certain death or possible survival." Elena's voice remained steady. "Sir, I understand protocols. I understand liability. I understand that what I'm proposing sounds impossible. But I've worked in places where impossible was just another day's challenge. And I'm telling you this can work." "Where?" Thornton demanded. "Where did you learn this technique? Show me literature. Show me studies. Show me something beyond your word." "There is no literature," Elena said simply. "There are 7 patients in 3 different countries who are alive today, because I adapted cardiac support technology to work in conditions where traditional approaches failed. That's my evidence." Patricia Webb pushed forward, her voice breaking. "Dr. Thornton, please. If she says there's a way, let her try. He's my son. He's 16 years old. He has his whole life ahead of him. Mrs. Webb, Thornton began, but Elena interrupted. Marcus has approximately 4 hours before cardiac function declines to the point of irreversible organ damage. Elena's voice was clinical now, presenting facts rather than appeals. If we proceed, we need OR time, perfusion team, and full cardiac surgical support. Dr. Park as first assist, and we need to move now. The ER fell silent again. Every eye was on Thornton, waiting for the decision that would determine whether Marcus Webb lived or died. The chief surgeon looked at Elena, at the dying boy, at the desperate mother. His face showed the struggle of a man whose entire career had been built on protocol, confronting a situation where protocol offered no solutions. Part 5. Dr. Thornton stood motionless for what felt like an eternity, but was only 15 seconds. His eyes moved from Elena to Marcus, whose monitors showed declining cardiac function with each passing moment. The decision he made in the next few seconds would determine whether a 16-year-old boy lived or died. "Dr. Vasquez," he said finally, his voice carefully controlled. "What exactly are you proposing?" "Improvised biventricular mechanical support," Elena replied immediately. "I'll cannulate the left ventricle through a modified apex approach and the right ventricle through the pulmonary outflow tract. External pump system provides complete cardiac support while his heart rests and we wait for transplant allocation." "That's not standard VAD placement," Dr. Park interjected, though his tone was more curious than critical. "You're talking about non-approved cannulation sites. Standard VAD won't work in acute trauma with this anatomy," Elena explained. "His ventricles are too dilated and damaged. Traditional inflow cannulas would cause more harm. But direct apex cannulation with epicardial support distribution? I've seen it work when nothing else would." "Seen it where?" Thornton demanded. "Show me one published case study, one peer-reviewed article, one shred of evidence beyond your word." Elena met his gaze without flinching. "There are no published studies. There are 7 living patients across 3 continents who survived because I adapted technology to circumstances. That's my evidence, Dr. Thornton. People who are breathing today because protocol took a back seat to survival. The ER around them continued its controlled chaos. Other trauma patients were being stabilized, chest tubes placed, emergency procedures initiated. But every person in Marcus's trauma bay was focused on this conversation, this impossible decision, this moment that would define what kind of hospital St. Michael's truly was." Mrs. Webb moved closer, her voice breaking but determined. "I don't care about published studies. I care about my son. Dr. Thornton, if she says there's a chance, please, let her try." Marcus's monitor alarmed. Blood pressure dropping to 80/40. Heart rate climbing to 130. The boy was running out of time. Elena's voice remained steady. "We have maybe 90 minutes before cardiac function deteriorates beyond recovery. If we're going to do this, we need OR1, full perfusion team, and every piece of cardiac support equipment this hospital has. Dr. Park, I'll need you as first assist. You'll need to trust my judgment on cannulation placement even when it looks wrong." Park looked at Thornton, waiting for the chief's decision. "Sir?" Thornton closed his eyes briefly. Elena could see the war playing out behind his expression. 15 years of protocol-driven success versus 1 moment of desperate innovation. Career-ending liability versus a teenager's life. The weight of impossible choices. When he opened his eyes, something had shifted. "Dr. Vasquez, if this procedure fails, if Marcus Webb dies on that table, both our careers are finished. The hospital will face lawsuits. The board will demand answers. Everything I've built here could collapse." "Yes, sir," Elena said simply. "That's all true. And if it succeeds, then a 16-year-old boy gets to live long enough to receive a heart transplant." Elena's voice carried absolute conviction. "And maybe we prove that innovation matters as much as protocol. That experience earned in difficult places has value even in elite medical centers." The silence stretched. Marcus's alarm sounded again. 75/38. Time was running out. "Dr. Park," Thornton said finally, "prep OR1 for emergency cardiac procedure. Get the perfusion team assembled." Elena felt something release in her chest, but Thornton wasn't finished. "Dr. Vasquez, I'm authorizing this procedure under emergency experimental protocols. Mrs. Webb will need to sign consent, acknowledging the risks. You will have complete surgical autonomy, but I will be observing. If at any point I determine the patient's life is in greater danger from the procedure than from the underlying condition, I reserve the right to stop the operation. Understood, Elena said. And Dr. Vasquez, Thornton's voice carried an edge now, you better be right about this. Because if you're not, I'll make sure you never practice medicine again. If I'm wrong, Elena replied quietly, I won't want to practice medicine again. Patricia Webb was already signing consent forms, her hands shaking but determined. The ER nursing staff began mobilizing Marcus for transport to OR1. Dr. Park was on the phone coordinating the surgical team. Cole, the paramedic, stood watching with an expression that mixed respect and recognition. Dr. Vasquez, Cole said as the team prepared to move. In Aleppo, you told us that field medicine wasn't about having perfect conditions. It was about making impossible decisions with whatever you had available. I remember, Elena said, checking Marcus's IV lines. This kid, he's getting the same chance you gave my sergeant. Cole's voice was firm. Don't let these people make you doubt what you know works. Elena nodded once, then followed the gurney toward the elevators. Dr. Park fell into step beside her. You understand this could destroy both our careers? I understand that Marcus Webb deserves a chance to graduate high school, Elena replied. Everything else is secondary. They entered the elevator. Through the closing doors, Elena could see Thornton on his phone, likely alerting the hospital board to what was about to happen. Patricia Webb stood with a nurse, her face a mixture of hope and terror. The ER continued its organized chaos, but for one moment, everything seemed to pause. In the OR, Elena stood at the scrub sink, methodically preparing. This was familiar territory. She'd done this hundreds of times in places where the sink was a bucket and the soap was whatever you could find. Where the OR was a tent and mortar fire provided the background music. Where every procedure was experimental, because textbook medicine didn't account for conflict zones and failing infrastructure. Dr. Park scrubbed beside her. Tell me honestly, he said quietly. Those 7 survivors you mentioned. What happened to the 2 who didn't make it? One had sustained too much organ damage before I could intervene. Elena replied, her voice clinical but carrying an edge of old pain. Started the procedure 4 hours too late. The other, we lost power mid-surgery. Generator failed and we had to finish by hand pump. He survived the procedure, but died 3 days later from complications. Park absorbed this. And you're confident Marcus isn't too far gone? His organ function is still adequate. We have electrical power that won't fail. And we have time, barely, to execute properly. Elena finished scrubbing. Yes, I'm confident. Not certain, but confident. What's the difference? Certainty is what you have when you're working with proven protocols in ideal conditions, Elena said. Confidence is what you have when you've faced this situation before and know what success requires. I can't promise Marcus will survive, but I can promise I'll do everything humanly possible to give him that chance. They entered OR1 where the surgical team was completing final preparations. The perfusion equipment stood ready, machines that would take over the function of Marcus's failing heart. The anesthesiologist, Dr. Patel, looked up from her preparations. Patient is ready for induction. Vitals are tenuous but stable enough for now. Elena positioned herself at the table. She took a breath, let her mind shift fully into the mode that had kept her functioning in impossible situations. Protocol dissolved. Hierarchy faded. There was only the patient, the problem, and the solution her hands would create. Time to first incision, she announced. We have one chance to get this right. Her eyes met each member of the surgical team. I need everyone's complete focus and trust. What I'm about to do will look unconventional. You might think I'm making mistakes. You might want to speak up, but I need you to trust that I know what I'm doing. The team nodded. Above, in the observation gallery, Dr. Thornton settled into his seat, his expression unreadable. Beside him, residents and attending physicians assembled to witness what might be groundbreaking surgery or catastrophic failure. Elena looked down at Marcus Webb. 16 years old, basketball player, son, patient. someone's whole world lying unconscious and dying on her table. She picked up the scalpel. "Let's save a life," she said. Part 6. The scalpel touched Marcus Webb's chest at 3:14 in the morning. Elena's incision was confident, deliberate, following the path her mind had mapped during the preparation. Median sternotomy. The blade moved through skin, subcutaneous tissue, exposing the sternum beneath. "Sternal saw," she said calmly. The instrument was placed in her hand. In the observation gallery, Dr. Thornton leaned forward, his experienced eyes tracking every movement. Beside him, residents watched with mixture of fascination and dread, knowing they were witnessing either revolutionary medicine or career-ending catastrophe. "Saws through," Elena announced. Retractor placement. The sternal retractor opened Marcus's chest, exposing the pericardium that contained his failing heart. Dr. Park positioned himself across from Elena, ready to assist but uncertain what he was about to witness. "Pericardium appears tense," Park observed. "Possible effusion from the trauma." "Confirmed," Elena said, her gloved hand gently palpating the tissue. "I'm opening now." She made a careful incision in the pericardial sac, and immediately bloody fluid welled up. Hemopericardium as expected. "Suction." The surgical nurse provided suction, clearing the field. As the blood drained away, Marcus's heart came into view, and the entire surgical team drew breath. The organ was dilated, beating weakly, the anterior wall showing visible contusion from the accident's impact. "Jesus," Park whispered. "The myocardial damage is extensive. Anterior wall contusion approximately 8 centimeters in diameter," Elena narrated, her voice clinical despite the severity. "Ventricular function is minimal. Both chambers are dilated beyond normal parameters. This heart cannot support life without mechanical assistance." In the gallery, one resident turned to another. "She's going to cannulate that? It looks like it'll rupture if she touches it wrong." Dr. Thornton said nothing, but his hands gripped the observation rail tightly. In the OR, Elena continued her assessment. "Dr. Patel? Current hemodynamics?" The anesthesiologist consulted her array of monitors. "Blood pressure 70/40 and falling, heart rate 140, oxygen saturation 86%, despite maximum support. He's decompensating." "Time to cannulation," Elena announced. "Dr. Park, I need you to gently elevate the apex of the left ventricle. Don't compress, just support." Park's hands moved carefully, following her instructions. His extensive surgical experience told him this approach was unconventional, but Elena's confidence was absolute. The apex came into view, the damaged muscle visible even through the epicardial surface. "This is the critical moment," Elena said, her voice steady but carrying new intensity. Traditional VAD placement would use the lateral wall, but with this degree of contusion, that approach would cause rupture. "I'm going directly through the apex, which will allow me to position the cannula inflow in the center of the ventricular chamber without disrupting the damaged tissue." "That's not approved technique," Park said, though his tone was observational rather than critical. "Approved technique doesn't account for this specific injury pattern," Elena replied. "Apex cannulation with reinforced suture rings. I need the 14mm cannula with felt pledgets prepared." The perfusion team moved quickly, assembling the cannulation equipment. This was specialized hardware, typically used in different configurations, but Elena was adapting it for her improvised approach. "Pledgeted sutures placed," she continued, working with precision that seemed impossible given the friable, damaged tissue she was manipulating. Each stitch was exact, reinforcing the tissue without tearing through it. "This is field surgery technique adapted for cardiac application. Multiple interrupted sutures distributing tension across maximum surface area." The residents in the gallery were leaning so far forward they were nearly pressing against the glass. One pulled out his phone, recording the procedure despite hospital policy. This would be discussed in surgical conferences for years, one way or another. "Cannula ready for insertion," Elena announced. "On my mark, advancing now." The cannula slid through the reinforced entry point into Marcus's left ventricle. For a heartbeat, nothing happened. Then Dr. Patel's voice carried through the OR. "Blood pressures, holding, no immediate deterioration. Cannula in place," Elena confirmed. Securing now. Her hands worked rapidly, completing the fixation sutures that would hold the cannula stable. Left ventricular inflow established. Now for the right ventricle. Dr. Park was watching with growing understanding. You're creating complete biventricular bypass. The heart won't be pumping at all. The machines will do everything. Correct? Elena said. His myocardium needs complete rest to recover from the trauma. Partial support won't be enough. Park, I need you to expose the right ventricular outflow tract. As Park repositioned, one of the surgical nurses whispered to her colleague, I've been in cardiac surgery 12 years. Never seen anything like this. The right ventricular cannulation was even more technically demanding. The pulmonary outflow tract was smaller, the tissue more delicate, and the margin for error essentially zero. Elena worked with focused intensity, her movements economical but precise. Right ventricular cannula advancing, she narrated. Position confirmed by palpation. The cannula slid into place, and she began the securing sutures with the same reinforced technique she'd used on the left ventricle. Both cannulas placed, she announced, preparing outflow cannulation to aorta and pulmonary artery. This will create complete cardiac bypass with independent control of systemic and pulmonary circulation. Dr. Thornton's phone buzzed. A text from the hospital board chairman. Richard, what exactly is happening in that OR? Multiple board members are getting calls from night staff about experimental procedure on a minor. Thornton silenced his phone without responding. His eyes never left the surgical field. Elena was connecting the outflow cannulas now, creating the pathways that would return oxygenated blood to Marcus's body while his heart rested. The technical complexity was extraordinary, each connection requiring perfect placement and absolutely leak-free seals. Aortic outflow connected, she reported. Pulmonary outflow connected. Dr. Park, initiate pump flows. Start at 2 liters per minute and increase gradually. The perfusion team activated the pumps. In Marcus's chest, his heart continued its weak contractions, but now external machines were taking over the work of circulation. The monitors began to change, slowly but measurably. Systemic pressure rising, Dr. Patel reported, wonder in her voice. 70/45, 80/50, 90/55. Increase flows to 4 liters, Elena directed. Watch for any signs of ventricular distension. The pumps increased their output. Marcus's heart, no longer bearing the burden of circulation, began to decompress. The distended chambers grew slightly smaller as the mechanical support took over completely. This is remarkable, Park said quietly. His cardiac output is being maintained entirely by external pumps. I've read about this theoretically, but never seen it executed. 4.5 liters per minute achieved, the perfusion specialist announced. Flows are stable. Pressures are optimal. Dr. Patel's voice carried new energy. Blood pressure 100/60. Heart rate dropping to 90. Oxygen saturation 94% and rising. Organ perfusion is improving dramatically. In the gallery, the residents erupted in whispered excitement. Dr. Thornton remained silent, but something in his expression had shifted. He was watching not a locum surgeon improvising desperately, but a master technician executing a procedure most surgeons couldn't imagine, let alone perform. Then Marcus's monitor alarmed. High-pitched, urgent, cutting through the OR's controlled tension. Ventricular fibrillation, Dr. Patel called out. He's lost coordinated cardiac rhythm. The surgical team tensed. Elena's voice remained absolutely steady. Expected complication from the trauma and manipulation. Internal paddles ready. 20 joules. The internal defibrillator paddles were placed directly on Marcus's heart. Clear, Elena said. Everyone stepped back. Shock delivered. The heart muscle convulsed, then fell back into fibrillation. No rhythm change. 30 joules, Elena said, repositioning the paddles fractionally. Clear. Another shock. Another failure to convert. In the gallery, one resident grabbed another's arm. This is it. This is where it falls apart. Doctor. Thornton stood motionless, his vast experience telling him they were seconds from losing the patient. One more failed attempt, and Marcus's heart, would be irretrievably damaged. Elena's voice cut through the tension. Lidocaine 100 milligrams IV. Direct cardiac injection. Prepare for 50 joules internal defibrillation. That's maximum voltage, Park said. At that level, you could damage the myocardium beyond recovery. At this level, Elena replied calmly, we either convert the rhythm or we lose him. There's no middle ground. She took the syringe of lidocaine and injected directly into Marcus's heart muscle. Count of 3. 1, 2, 3. Clear. 50 joules discharged directly into Marcus's heart. The monitor showed a flat line. 1 second. 2 seconds. 3 seconds of absolute silence in OR 1. Every eye fixed on the cardiac monitor. Every breath held. Then, a blip. Another. Another. Sinus rhythm established. Weak, but regular. Rhythm converted, Dr. Patel announced, her voice shaking slightly. Heart rate 70. Regular rhythm. He's stabilized. The OR released its collective breath. Elena's hands moved immediately to assess the heart, checking for damage from the defibrillation. Myocardium appears intact. No visible burns or rupture from electrical discharge. She looked up at Dr. Park. That's the moment where field experience matters most. Knowing exactly how much you can push before causing irreversible harm. Park nodded slowly. Where did you learn to read that line so precisely? Places where you only got one chance, Elena replied. Places where if you guessed wrong, you lived with the consequences. She began her final checks of the cannula sites, the pump connections, the surgical field. Everything is secure. Flows are stable. He's completely supported by mechanical circulation. She stepped back from the table. Now we wait for a transplant. In the observation gallery, Dr. Thornton finally released his grip on the rail. His hands were shaking slightly. He'd practiced surgery for 3 decades, taught hundreds of residents, performed thousands of procedures, and he'd just watched something he'd never imagined possible. One resident turned to another, his voice awed. Did that just actually work? Below, Elena was beginning to close Marcus's chest, her technique as flawless as everything that had come before. The impossible had become reality. A 16-year-old boy who'd been declared unsavable was now alive, his heart resting while machines sustained his life, waiting for a donor organ that might allow him to actually survive. Patient stable, Elena announced to the OR. Projected time to transplant availability is approximately 2 weeks based on current waitlist position and his increased priority status. She glanced at the surgical clock. Total procedure time, 4 hours, 18 minutes. Dr. Park spoke the thought everyone was thinking. I've been a cardiac surgeon for 12 years. That was the most extraordinary surgery I've ever witnessed. Elena removed her surgical gloves, her expression unchanged. It was what needed to be done. That's all. But everyone in that OR knew they'd just witnessed something far more significant than a successful procedure. They'd seen the impossible become possible through skill, experience, and absolute refusal to accept defeat. Now the question became whether Marcus Webb would survive long enough for that miracle to matter. Part 7. 5 days after Marcus Webb's surgery, Dr. Elena Vasquez stood outside the cardiac ICU, watching through the observation window. The 16-year-old lay in bed, chest sutured closed, mechanical pumps humming quietly as they sustained his circulation. His mother sat beside him, holding his hand, reading to him from a basketball magazine, though he remained sedated. Elena hadn't left the hospital for more than a few hours at a time since the procedure. Old habits. When you were responsible for keeping someone alive with improvised technology, you stayed close. You watched for complications. You anticipated problems before they became catastrophes. Dr. Vasquez. Dr. Thornton's voice came from behind her. His tone was different now. Less authoritative, more contemplative. The board is meeting in conference room 3. They'd like to speak with you. Elena turned to face him. Am I being dismissed? Thornton's expression was unreadable. That depends on the conversation we're about to have. They walked in silence through the hospital corridors. Staff members watched them pass, whispers following in their wake. The locum surgeon who'd defied the chief. The experimental procedure that had shocked the medical community. Marcus Webb's survival had become legend in 5 days, spreading through medical networks faster than any journal publication. The conference room held 7 board members, all watching Elena enter with expressions ranging from curiosity to concern. Patricia Chen, the board chairwoman, gestured to an empty seat. "Dr. Vasquez, thank you for joining us. Please, sit." Elena remained standing. "With respect, I prefer to receive bad news while standing." Several board members exchanged glances. "Who said this was bad news?" Chen asked. "Experience." Elena kept her voice neutral. When hospital boards request meetings 5 days after unauthorized experimental procedures, it's rarely to offer congratulations. Chen's expression softened slightly. "Dr. Vasquez, Marcus Webb is alive because of your intervention. His transplant placement has been elevated to status 1, and preliminary donor matching shows a potential heart within the next 10 days. You accomplished something our chief of surgery said was impossible." "So why does this feel like a termination meeting?" Elena asked directly. "Because we need to understand who you are," Chen replied. "Your CV shows impressive credentials but significant gaps. Medical degree from Hopkins, surgical residency at Mass General, then 7 years with Médecins Sans Frontières. Syria, Yemen, Congo, South Sudan. Over 300 cardiac surgeries performed in conflict zones." She paused. "But what your CV doesn't explain is why you're working temporary positions instead of accepting permanent roles at prestigious medical centers." Elena was quiet for a moment. "Because prestigious medical centers require adherence to protocols that don't account for situations where protocol fails. Because I've seen too many administrative meetings about liability when I should have been in ORs saving lives." "You don't trust institutional medicine," board member David Reeves observed. "I trust medicine," Elena corrected. "I don't trust bureaucracy that prioritizes process over patient outcomes." Dr. Thornton leaned forward. "Dr. Vasquez, may I speak candidly?" Elena nodded. "When you questioned me in that first briefing, I was insulted." Thornton's voice carried an edge of admission. "When you escalated Robert Morrison's surgery without authorization, I was furious. And when you proposed that experimental procedure for Marcus Webb, I thought you were reckless to the point of malpractice." Elena met his gaze steadily. "And now? Now I've spent 5 days reviewing your technique, researching field medicine protocols, and consulting with colleagues who've worked in conflict zones." Thornton's expression shifted. "What you did in that OR wasn't recklessness. It was expertise earned under conditions most surgeons never face. You've developed skills that civilian medicine desperately needs, but doesn't know how to value. Where is this going?" Elena asked. Chen pulled out a document. "St. Michael's would like to offer you a permanent position as Director of Innovative Cardiac Surgery. Full autonomy, dedicated OR time, budget for research into field-adapted techniques. We want you to develop a program training surgeons in improvised cardiac support methods." Elena stared at the document. "You want me to teach other surgeons techniques that aren't approved by any medical board?" "We want you to expand the definition of what's medically possible," Chen replied. "Your methods work. Marcus Webb is alive because you refuse to accept conventional limitations. We need more surgeons who think that way. But there's a catch," Elena said. "There's always a catch." Reeves spoke up. "We need to understand why you left MSF. Your record shows 7 years of exceptional work, then abrupt departure. No explanation in your file." Elena's expression hardened. "Some files are sealed for reasons. We need to know those reasons before offering permanent positions," Reeves insisted. "No, you don't." Elena's voice carried finality. "You need to know whether I can do the job you're offering. My past medical performance speaks for itself." "Dr. Vasquez," Chen said gently, "we're not trying to invade your privacy, but this position requires trust. Complete trust. And that requires understanding." "Understanding what? That I left because I was tired? Because I made decisions that haunt me?" Elena's composure cracked slightly. "You want to know why I work temporary positions? Because permanent positions mean permanent responsibility for things that go wrong despite perfect technique." "What went wrong?" Thornton asked quietly. Elena was silent for a long moment. Then she began speaking, her voice distant. "Yemen, 2021. Pediatric cardiac unit in Sania. We had 3 children who needed emergency surgery. I had supplies for maybe 2 procedures. I triaged, made the call. Operated on the 2 with best survival probability. She paused. The 3rd child died waiting. That's proper triage protocol, Chen said. You made the right medical decision. Tell that to her mother. Elena's voice was tight. Tell her that medical protocol required sacrificing her daughter so 2 other children could live. Dr. Park, who'd been silent until now, entered the room with a folder. Sorry, I'm late. He set the folder on the table. Elena, I tracked down medical records from that Sanaa mission. That 3rd child? The one you think you failed? Elena's eyes closed. I know what happened. I was there. You weren't told everything. Park continued. That child had undiagnosed Ebstein's anomaly with severe tricuspid regurgitation. Even with surgery, her survival probability was less than 15%. The cardiologist on site confirmed it after you'd already made your triage decision. You didn't choose between 3 viable patients. You chose correctly between 2 you could save and 1 who was likely unsavable regardless. Elena's eyes opened, confusion and pain mixing in her expression. Nobody told me that. Because the mission was chaotic and you left 2 weeks later, Park said gently. But the records are clear. Your triage decision was medically sound. Those 2 children you saved? One is finishing university. The other became a physician, inspired by the doctor who saved her life. Elena sat down finally, the weight of 3 years of guilt pressing against new information. I thought I'd failed her. You made an impossible decision with the information available, Thornton said. That's what field medicine requires, and it's exactly why we need you here, teaching others how to handle situations where perfect information doesn't exist. Chen pushed the contract forward. Dr. Vasquez, we're offering you a chance to multiply your impact. Every surgeon you train will carry your techniques to their ORs. Every patient they save using your methods will owe their life to your willingness to innovate under pressure. Elena looked at the document. This isn't just a job offer. This is asking me to stop running. Maybe, Chen agreed. Or maybe it's asking you to stop punishing yourself for decisions that weren't failures. What are the conditions? Elena asked. 3 requirements, Thornton said. First, you develop comprehensive training in field-adapted cardiac techniques. Second, you serve as consultant on complex cases where standard protocols aren't sufficient. Third, you mentor surgeons who've experienced similar trauma, who carry guilt for patients they couldn't save. You want me to be therapist and surgeon? We want you to be what you already are, Park said. Someone who understands that medicine isn't just about technique. It's about carrying the weight of impossible choices and still showing up to save the next life. Elena picked up the pen, then hesitated. If I accept this, Marcus Webb can't be the only success story. There will be failures. Patients who die despite everything I try. Can this institution handle that? This institution has handled failure before, Chen said. What we haven't handled well is innovation. You're offering us a chance to be better, to save patients we currently give up on. That's worth the risk. Elena signed the document. The pen felt heavy, like she was signing away 3 years of protective distance. When do I start? You already have, Thornton replied. 3 residents have requested to work with you. Dr. Park has volunteered to co-develop the training program, and Marcus Webb's case has attracted interest from cardiac surgeons across the country who want to learn your techniques. 3 months ago, you told me I was just a locum covering routine cases, Elena said to Thornton. 3 months ago, I was wrong, Thornton admitted. Sometimes the most valuable lessons come from admitting our limitations and learning from those who exceed them. Outside the conference room, Patricia Webb waited. When Elena emerged, the older woman stood quickly. Dr. Vasquez, the transplant coordinator, just called. They found a heart. Marcus gets his transplant tomorrow. Elena felt something release in her chest. Perfect match? Perfect match, Patricia confirmed. Her eyes filled with tears. You gave him this chance. You refused to give up when everyone else had. He's not through this yet, Elena cautioned. Transplant surgery is complex, and recovery will be challenging. But he's alive to face those challenges, Patricia said. That's everything. Later that evening, Elena stood in Marcus's ICU room. The mechanical pumps continued their rhythmic work, sustaining a life that 5 days ago had been declared over. Marcus stirred, his sedation lightened in preparation for tomorrow's transplant. His eyes opened, confusion giving way to awareness. "Dr. Vasquez?" "Hey, Marcus," Elena said gently. "How are you feeling?" "Like I got hit by a bus." He managed a weak smile. "Oh wait, I did get hit by something." His expression turned serious. "They told me I was dying, that there was nothing they could do." "There was a way," Elena said simply. "Just not a conventional one. Thank you for finding it." Marcus's voice was hoarse but sincere. "Mom said you fought for me when everyone else stopped fighting." "I did what any good surgeon should do," Elena replied, refused to accept impossible as final. Marcus's eyes were closing again, exhaustion claiming him. "Tomorrow I get a new heart. Tomorrow you get a new chance," Elena corrected. "Make it count." As she left the ICU, Dr. Park met her in the hallway. "Ready for tomorrow? The transplant team wants you to assist." Elena nodded. "Let's finish what we started." 3 months later, as the outline specified. But that's a story for the next section. Part 8. 3 months after Marcus Webb's groundbreaking surgery, Dr. Elena Vasquez stood in the simulation lab watching a group of cardiac surgeons from across the country practice the improvised biventricular support technique she'd developed. The room was filled with specialized training equipment, anatomical models, and physicians eager to learn methods that textbooks had never taught them. "This is the critical cannulation point," Elena explained, demonstrating the apex approach on a high-fidelity cardiac model. Traditional VAD placement assumes stable anatomy. Field-adapted techniques account for damaged tissue, compromised structures, situations where textbook methods will fail. Her hands moved with the precision that had become her trademark. "You're not just learning a procedure. You're learning to think beyond protocol, when protocol isn't enough." Dr. James Park stood beside her, co-teaching the program they'd built together. "The key principle," he added, "is recognizing when standard approaches will cause more harm than good." Dr. Vasquez has performed over 300 cardiac surgeries in conflict zones. That experience taught her to read situations most civilian surgeons never encounter. In the back of the room, Dr. Thornton observed with an expression that had transformed from skepticism to respect over the past months. Beside him, representatives from the World Health Organization took notes on the training methodology. This wasn't just a hospital program anymore. It was becoming a blueprint for global cardiac care innovation. During the break, a young surgeon approached Elena nervously. "Dr. Vasquez, I'm Dr. Sarah Chen. I just finished my cardiac fellowship, and I'm about to start at a rural hospital with limited resources. Your techniques, they could save lives where I'm going, but I'm afraid of making mistakes, afraid of trying something unconventional and failing." Elena studied the younger surgeon, seeing her own doubts reflected back. "Failure is part of medicine," she said quietly. "I've lost patients despite perfect technique. The question isn't whether you'll fail. It's whether you'll let fear of failure prevent you from trying to save someone who has no other options." "How do you live with the losses?" Sarah asked. "You carry them," Elena replied. "You learn from them. You use that knowledge to save the next patient." She paused. 3 months ago, I was carrying guilt from a triage decision I made in Yemen. A child who died while I saved 2 others. I thought I'd failed her. What changed? I learned that the burden I'd been carrying was based on incomplete information. That child had conditions that made survival unlikely regardless of my decision. But more importantly, I learned that the 2 children I did save, one is finishing university. One became a doctor. Elena's voice strengthened. "The point isn't perfection. It's maximizing who you can save with the skills and resources available." That afternoon, Elena visited Marcus Webb in the outpatient cardiac rehabilitation center. The 16-year-old was on a treadmill, his transplanted heart functioning perfectly, his recovery exceeding all projections. His mother, Patricia, sat nearby, watching with the fierce protectiveness of someone who'd nearly lost everything. "Dr. V," Marcus called out, slightly breathless but grinning. "Check it out. 2 miles without stopping. Coach says I might be able to play basketball again next year." "Carefully," Elena cautioned, but her smile was genuine. "Your new heart is working beautifully. But you need to respect its limits. Limits? Marcus scoffed good-naturedly. You taught me that limits are just challenges waiting to be overcome. I taught you that some limits exist for good reasons, Elena corrected. Medical recovery is one of them. She checked his cardiac monitor readings, satisfied with what she saw. But you're progressing remarkably well. Your willingness to fight, to survive, that made the difference. Patricia approached, her eyes glistening. Dr. Vasquez, I can never thank you enough. When Dr. Thornton said it was over, you gave us hope. You gave us a miracle. I gave you a chance, Elena said. Marcus did the rest. She looked at the young man on the treadmill, living proof that refusing to accept defeat could create possibilities where none had existed. This is why we do this work. Moments like this. Later, Elena stood in her new office, reviewing proposals for expanding the innovative cardiac surgery program. Applications from surgeons wanting to train with her filled 3 file folders. Requests for consultation on complex cases arrived daily. What had started as one impossible surgery had grown into something larger than she'd imagined. Her phone buzzed. A message from Cole Jenkins, the paramedic who'd recognized her in the ER that crucial night. Doc, got a situation. Rural hospital in Vermont has a cardiac trauma case. They're saying it's impossible. Sound familiar? They're asking for you. Elena looked at the message, then at her schedule. Tomorrow she was teaching. The day after, consulting on 2 complex cases. The week after that, presenting at a national cardiac surgery conference. But this message was about a patient who needed someone willing to see possibility, where others saw impossibility. She typed her response. Send me the case details. I'll consult remotely and guide them through it. If necessary, I'll fly out tonight, because that's what this work meant. Not just performing miracles herself, but teaching others that miracles were possible, multiplying her impact beyond what one surgeon could accomplish alone. That evening, Dr. Thornton found her in the cardiac ICU, reviewing patient files. He'd become not just a colleague, but a mentor who'd learned as much as he'd taught. Elena, he said, the board wants to expand your program nationally. Partnerships with 10 major medical centers. Federal funding through NIH. You'd be training hundreds of surgeons in field-adapted techniques. That's a lot of administration, Elena said carefully. A lot of meetings, committees, bureaucracy. It's also a lot of lives saved, Thornton countered. Every surgeon you train will carry your techniques to their hospitals. Every patient they save using your methods multiplies your legacy. Elena thought about the child in Yemen, about Marcus Webb, about all the patients waiting for someone willing to try when others had given up. My legacy isn't about numbers, she said finally. It's about changing how we think about impossible. Teaching surgeons that innovation matters as much as protocol. That experience from unconventional sources has value. Then teach them, Thornton said simply. Show the world what you showed us. That sometimes the most important medical advances come from the most unexpected places. 6 months post-transplant, Marcus Webb returned to St. Michael's for his final major checkup. His transplanted heart had integrated perfectly. His cardiac function was normal. By every measure, he was a healthy teenager with his whole life ahead of him. Elena performed the examination herself, noting with satisfaction how far he'd come from that night in the ER when everyone else had said it was over. Your heart function is excellent, she told him. Ejection fraction is 60%. No signs of rejection, perfect rhythm. You're cleared for normal activities, including competitive basketball. Marcus's grin could have lit the entire hospital. I'm going to play college ball, Dr. V. Maybe even go pro. All because you didn't give up on me. All because you were worth fighting for, Elena corrected. Remember that when you face challenges in your life. Remember that impossible is just another word for not tried yet. As Marcus and his mother left, Elena returned to her office where a small collection of items had accumulated over the months. A photo from Marcus showing him in his basketball uniform. A letter from one of the children she'd saved in Yemen, now a medical student. A note from Dr. Thornton that simply said, You changed how this hospital thinks about medicine. Thank you. These were the measures of success that mattered. Not journal publications or awards. Lives saved. Futures created. Possibilities realized. But Elena knew this was just the beginning. Across the medical world, countless patients were being told their cases were impossible. Countless surgeons were accepting conventional limitations without questioning whether other approaches might work. The work she'd started at St. Michael's was spreading, but there was so much more to do. What happens when medicine stops innovating? When protocol becomes more important than patient outcomes? When we accept impossible as final instead of challenging it? Elena Vasquez's story is one answer. But there are countless other medical professionals fighting similar battles, pushing similar boundaries, refusing to accept that some patients are beyond saving. Their stories matter. Their innovations could save lives. And by choosing to learn from them, to support unconventional approaches, to value experience from unexpected places, we create a medical community that saves more lives, helps more patients, and never stops pushing the boundaries of what's medically possible. If this story inspired you, share your thoughts in the comments below. Have you encountered situations where innovation mattered more than protocol? Where someone refused to accept impossible as final? Our community values you taking this journey with us. Your time matters. If this story moved you, we have more tales of medical innovation, impossible cases, and surgeons who refuse to give up. Why not explore another journey right now? And if you want to ensure you never miss our next inspiring medical story, subscribe and hit the notification bell. We'd be honored to welcome you into our community. Until next time, remember, impossible is just a challenge waiting for someone brave enough to try. Thank you for being here with us tonight.